Hello there, this is Dr. Brian Buchanan from the University of Alberta, bringing you this tutorial on ultrasound-guided vascular access. This tutorial was designed by a culmination of clinical experience and through these three key references. If you'd like to know more, I would suggest you take a look at these as they are very helpful. The purpose of this tutorial is to really hone your skills in the use of ultrasound in guiding central venous catheterization. This video should be viewed as an adjunct to the video in clinical medicine from the New England Journal of Medicine. This really is an excellent video as it demonstrates the entire procedure from start to finish. However, in this video, there is not proper attention paid with respect to the use of ultrasound, as it enhances the procedure, but it also adds a measure of complexity. We will not cover indications, contraindications, consent, risks, sterile preparation, and devices other than a triple lumen central venous catheter. We hope to keep this video brief and concise and improve your understanding and technical expertise with ultrasound. There are features common to every site for the use of ultrasound for venous cannulation. First of all, we're using ultrasound to identify anechoic vascular structures, short axis view of vascular anatomy, which are echo-free or anechoic. It helps to understand anatomy with respect to arterial and venous structures and other soft tissue, and to rule out thrombus with compression. Next, we use it for static or dynamic guidance. In the case of static guidance, we're really using it to help correlate external landmarks with underlying vascular anatomy, and then doing the rest of the procedure effectively blind. In dynamic guidance, we're using ultrasound all the way from entering to the skin all the way down to penetration of the vascular wall. Finally, ultrasound can be used to enhance the Seldinger technique to better understand wire cannulation and visualization. To review briefly, the Seldinger technique is a method to cannulate hollow viscera or vascular structures. In this case, it'll be the internal jugular vein. First, the vessel is cannulated with the needle. After a successful aspiration of venous blood, a guide wire is advanced through the needle. This has a noticeable J-hook on the end to prevent vascular penetration. Once the wire is advanced to a suitable depth, the needle is then removed with the wire left in place. After this, the next steps really revolve over a catheter over the wire technique with sequential dilatation and insertion of the central venous catheter. This tutorial focuses on IG cannulation, but again, many of these principles will remain the same for other sites. To go through our checklist, first of all, we will discuss your assessment prior to preparation for the procedure. Next, preparation and insertion, confirmation and placement, and then finally on to ensuring correct placement and to ruling out obvious complications. First of all, know your machine. I can't stress this enough. Make sure you've properly adjusted the depth and gain to highlight your anatomy. This can all be done even before you set up for the procedure. Next, examine your vascular anatomy with ultrasound with relation to the patient position you are performing the procedure in. For IG cannulation, the procedure should be done arguably in the Trendelenburg position, so make sure to examine your patient in this position. Understand the probe has a specific orientation. In this case, the marker is often proprietary. It can be a notch. It also can be a light. Many people will establish the side of the probe by tapping the end of the probe and examining the screen simultaneously. The screen also has an orientation, which has a screen marker here. In this case, from a right IJ approach at the head looking down towards the legs, so the probe is oriented to highlight the medial and lateral portion of the anatomy. In this case, we can see the artery and the corresponding internal jugular vein. You can check for patency and optimize site selection along the entire length of the internal jugular vein. Ultrasound does not supplant the need to understand anatomy, such as the orientation of the vessels with respect to the sternocleidomastoid. You should still aim for the mid portion of the neck, where the sternal portion of the SCM meets the clavicular portion of the SCM in the apex of that triangle. In this case, we can see in real time how we're visualizing the IJ. We can see on screen left the carotid with the corresponding IJ on the right. Again, oriented medial and lateral on the right side of the neck. We can also use ultrasound to help understand the depth of the vein. In this case, we can see it's 1 centimeter from skin to penetration of the vein. And this helps to understand how deep that needle really should be going when you're cannulating the vessel. We can also use ultrasound to compress the vein, as a patent vein should fully compress, as demonstrated here. If the vessel cannot be compressed to its full extent and you begin to distort the arterial anatomy, there is a high chance the patient has a thrombus in that area. You can also use ultrasound before your assessment to scan up and down the neck. This helps to give you a better understanding of the anatomy of the vasculature, but also any possible anatomical obstruction to performing the procedure. In selecting the ideal site, it is best for the vessels to be seen side by side. In this case, we can see the IJ is directly overlapping the carotid. This is a less than ideal site, as one may cannulate the IJ and pass through the posterior wall into the carotid artery. If you plan to turn the patient's head during the procedure, make sure you are cautious to observe the relationship of the vasculature as the head is turned, as this may lead to overlap of these vessels. Next, you can look for engorged superficial veins, as seen here. It is best to avoid these veins if at all possible. An IJ anatomy is not always easy to delineate. In this article by Hoffman et al., they characterize vascular anatomy in a number of patients. And we can see here this relationship differs quite dramatically patient to patient. In terms of imaging techniques for vessel cannulation, there are really two techniques that are largely cited in the literature. The first technique is called out of plane. In this case, we are seeing the vascular anatomy in cross-section. This is by far the most commonly used technique and is very effective, but carries the risk of passing through the plane of the ultrasound beam with the needle. On the right, we can see the in-plane technique, with the ultrasound probe placed along the longitudinal cross-section of the vessel. This may allow the entire length of the vessel to be seen, but also length of the needle. But again, this carries the risk of going out of plane and missing the tip of the needle. This in-plane technique requires far more experience to successfully perform. Ultrasound guidance is not foolproof. I can't stress this enough. There is a high risk you may pass out of the imaging plane. In this case here, we are actually seeing the shaft of the needle and not the tip of the needle. That's that movement you're seeing here in the near field. The fact is that the needle tip here is actually much deeper than you're led to believe. And so imaging the shaft of the needle will always look very similar to imaging the tip. So how do we get around this? We use the creep technique. And so we can see here that we always want to be a little bit advanced of the needle tip. As probe number 2, we can see here we must continually sweep to be in advance of the needle tip. These videos show a simultaneous recording of the short and long axis vessel cannulation in a gel mold. On image left, we can see the operator is continuously scanning in and out of plane to make sure he has the needle tip. On image right, we can see it is very easy to fall out of plane in our in-plane technique. So we can use a technique of visualizing the needle to help, first of all, freeze the skin of our planned site of entry. Now again, we will use the creep technique for venous cannulation, and therefore we will start roughly 5 millimeters distal to our probe. And as we enter the skin, we always want to make sure our probe is right at the tip of that needle as it enters. As we can see here, the person is carefully going back and forth to make sure they see the tip of the needle and not the shaft of the needle. As the needle is advanced, so is the probe to make sure, again, you are seeing the tip of the needle. The operator must carefully wash the barrel of the syringe itself and the screen, as once the vessel is penetrated, you will see a venous flash of dark blood, as shown here. The probe is placed down. The needle is stabilized with the left hand against the body of the patient. We can see dark non-pulsatile blood. Now we can see the wire is pass through this syringe. It should be passed with minimal resistance. Again, being sure to never let go of the wire. Once you're around 2.5 notches or 25 centimeters, the plastic casing can be taken off. Now, as the wire is advanced slowly, you may see an arrhythmia. If so, just remove the wire slowly and this arrhythmia will disappear. Ensure to keep the site clean. At this point in time, you can hold the wire with the knife side of your palm to compress the site, but also to simultaneously bend the wire in preparation for the next steps. Again, anytime the wire is bent, be careful not to kink the wire. Next, ultrasound can be used to confirm wire placement in the short axis, as shown here, all the way down to the brachiocephalic trunk, and also in the long axis. This helps to affirm that your wire is indeed in the venous vasculature. Next, moving on to incision dilatation. An 11 blade is used to make an external nick in the skin, just to allow introduction of the dilator and catheter, being careful to avoid nicking of the wire. Next, simultaneous compression and preparing the wire for the dilator. You'll notice the operator is careful to control the wire at all times. As the introducer is pushed in, it is given a small turning motion to dilate the tract. The dilator does not need to be introduced along its entire length, only enough to establish a tract to the vessel itself. As the dilator is withdrawn, expect much bleeding. Therefore, compress the site as the dilator is removed. Next, we will insert the triple lumen catheter. As the catheter is inserted over the wire, you will see the wire appear from one of the ports. In this case, it is the brown distal port. If you are uncertain, you can easily check this when setting up prior to catheter insertion. Notice the wire is held at all times and is fed through the catheter until it appears from that port. This is to make sure that the wire is not lost during the procedure. Once the wire is seen, it can be then held with the hand fixed and the catheter inserted over the wire. The catheter is advanced all the way in this case, as it is a right-sided IJ and a 15 centimeter catheter. The wire is removed and the fingers over the port to prevent a venous air embolism. Now the operator will withdraw from each port, flush the port, and then saline lock the port. Once the catheter is inserted, you can confirm catheter position with ultrasound. In this case, a short axis shot is seen here with the catheter displayed by this image. This can be tracked, again, all the way down from the IJ to the brachiocephalic trunk in the short and long axis. Finally, an X-ray is performed to confirm placement, ideally at the SVC-RA junction, also to rule out pneumothorax and hemothorax. That goes through our list from our pre-assessment, from our preparation and insertion, confirmation of placement, and our post-insertion check. Again, we can do an X-ray. There are also additional techniques in ultrasound, such as ruling out pneumo and hemothorax, that have not been covered in this tutorial, but will be covered in another tutorial. You can also transduce the ports for pressure if there's concern about unintentional arterial cannulation, and you can also send off a blood gas. Thank you for listening. You can check out our website at www.abacus.ca and follow us on Twitter at UAlberta Crit Care Ultrasound.